Please welcome our next speaker, Dr. Deb Thorp.
All right. I'm going to talk about two things. We were going to have two separate speakers, but the second one couldn't make it, so I'm going to do two topics. And the first one I'm going to talk about is endometriosis. And endometriosis is where the same kind of tissue that is inside the uterus, the lining of the uterus, grows outside the uterus. The most common places for that to grow are the ovaries or the area right behind the uterus, but it can grow anywhere, in your bladder, in your bowel, in your lungs. It can really grow anywhere. How do we know if somebody has it? Well, the first thing is we don't do anything to try to diagnose that unless somebody's having symptoms. The most common symptoms are pain, pain with your periods, severe pain with your periods, like really bad cramps, pain between your periods, pain when you're having sex, pain with bowel movements or urination, or you can have bleeding between your periods because the hormones don't always work right, and so sometimes you will get bleeding between your periods. And then sometimes you will bleed inside your belly a little bit with your periods or in between your periods if your hormones aren't working right. And that can cause blockage of the tubes, just like Dr. Deborah was talking about earlier, where the tubes can get blocked from infection. The tubes can get blocked from endometriosis as well. It can also cause parts to stick together that aren't supposed to be stuck. So the tubes and the ovaries aren't supposed to be stuck to the uterus. They aren't supposed to be like super glued together. But with endometriosis, they can be super glued together or super glued to the bowel or the bladder. And that can cause pain. Sometimes you will get a cyst on the ovary, and this can be little, can be just a centimeter. If they're really small, 1 to 3 centimeters, sometimes it's hard to tell if it's endometriosis or the kind of cyst you make when you ovulate. But when they get really big, then we know that there's something not right. 5, 6 centimeters, 10 centimeters, something like that. We talked about how it can cause infertility, but the other thing that endometriosis can cause is a higher risk of miscarriage. We don't really understand that, but we know that it's true. And so we try very hard to treat the endometriosis to make the woman comfortable. Treating it, if it's in its very mildest forms, doesn't really make you more likely to get pregnant, but it can help the pain so that getting pregnant isn't such a chore. The other thing that sometimes treating it, if it's more severe, will do is to restore the anatomy more closely back to normal, and then the tubes might work better. Ultimately, though, if the patient's not trying to get pregnant, we want to try to control her pain. And this is where a lot of the controversy comes in when I'm talking with some of my Somali patients, because I want to put them on birth control pills to try to help the pain. Birth control pills help. Another medication called Depo-Provera, which is the birth control shot, will help. And then there's another treatment that's a shot that makes you temporarily in menopause, and all of those things will help. Dr. Hu's treatment with the acupuncture helps a lot with the pain, and I encourage my patients to see her. But if you're having all this trouble with Depo-Lupron or birth control pills or Depo-Provera because you have the side effects and you're still having a lot of pain, and then sometimes we will do surgery and try to help you with that. We can try to take out the endometriosis. We can cauterize it with electricity. We can use a laser, all of those things to try to get rid of the endometriosis. But let's talk a little bit about what else endometriosis can do. We said it would cause problems with the tubes. Or the other thing that can cause problems with the tubes is the infections, like we talked about earlier this evening. If the tubes don't work, the sperm and the egg can't get together, or the sperm and the egg, once they're fertilized, can't travel all the way back down to the uterus. And that puts a patient at risk for having the pregnancy in the tube. Sometimes what needs to happen is that the tubes need to be taken out, and the patient needs to do something called in vitro fertilization. And I want to just cover that briefly tonight. In vitro fertilization is getting to be more and more popular because it works. It is where the eggs are taken from the woman, the sperm is taken from the man, and they are put together in a dish with special liquid, and that helps the eggs get fertilized. And after they grow for a couple of days into what we call embryos, they are put back in the woman's uterus. So how does a woman make enough eggs? She gets some medicine. Usually these are injectable medicines, but occasionally, in some patients, we'll use no medicine, or we'll use oral medication called Clomid. But in any case, what you want to do is help the woman make more than one egg if possible, usually 2, 3, 4, or more eggs. Not too many, but maybe 4. And you give the woman medicine, and you follow her very carefully with ultrasounds and blood tests. And when the eggs look ready, then the eggs are removed through a procedure where a needle is put into the cyst that the woman makes when she's making the egg, and those eggs are taken out, and that's done with the ultrasound to guide where the needle goes. And that can be a little uncomfortable, so we usually give people some medication to make it more comfortable during that part of the procedure. And then we put that with the sperm, as I said. Now, what are some of the problems with those medications? A few patients will have trouble with moodiness, headaches, nausea, bloating. But the most dangerous thing that can happen is something called ovarian hyperstimulation syndrome. And that's where the body takes a little bit of medicine, and then it makes a whole bunch of eggs. And it's like the ovaries go wild. It's like you opened up the switch, and to open up the dam, and man, everything keeps going. And the woman makes a lot of eggs, and the ovaries get really swollen. And when the ovaries get really swollen like that, sometimes then a lot of fluid will come into the belly, and she can get really bloated. She'll look like she's pregnant, even though she's not. And then she's more at risk to getting blood clots. And occasionally, like less than 1% of the time, she'll have problems with her kidneys or her liver with that. But usually, these things are very well controlled because we're watching you with blood tests and ultrasounds, and if it looks like that's what's happening, we stop the medication right away. So once we've retrieved the eggs and we've put them in the dish, and then we watch them grow. And we watch them grow for a couple of days. And usually then we take out the 2 best ones, maybe 1, maybe 2, maybe 3. It depends on the woman and the infertility specialist and her husband. The woman and the husband and the infertility specialist decide how many, because you don't want to have too many babies in there. Everybody thinks it's nice to have twins, or maybe we can get the whole family done and have triplets. But that puts you at increased risk for having pregnancy complications and preterm delivery being the most dangerous one for the babies. If the babies are born too early, they can have problems with asthma and their eyes and brain. So we don't want them to be born too early. So you don't want too many babies in there. We don't want that octomom kind of thing going on. We just want one, maybe two. But even two puts a woman at higher risk for preterm delivery. Even two puts a woman at higher risk for having high blood pressure with her pregnancy and diabetes with her pregnancy. So we would really like to avoid having more than one in there, and that's why you're careful about how many you put in. But what if you ended up with 6 embryos and you only put back 1 or 2? You can freeze them. They freeze very well. And then in a subsequent cycle, if you didn't get pregnant, we prepare the uterus with the right amount of hormones, and we can put back another 1 or 2, and that's very successful as well. And the success rates are very good, very good. Assuming that you're not going into menopause, then it doesn't work too well. If you're already old enough that you're going into your change, in vitro fertilization doesn't work very well any more than any other kind of fertility treatment. But if you're young and you have tubal problems, or sometimes even now we use it for patients that we couldn't figure out what the problem was, or if the man has not very much sperm or they don't move right, again, in vitro fertilization is typically used for that too, and it's very good with that. Sometimes you can even take the sperm and put it right inside the egg. That's called intracytoplasmic sperm injection, or ICSI, and that will sometimes help. So there's all kinds of things that can be done to try to help women. So I'm going to echo what Dr. Deborah said earlier. As soon as you think you're not getting pregnant fast enough, typically wait for a year, but if you're not getting pregnant after that, come on in. Come and talk to us, and we'll see what we can do to try to help fix the situation for you, because we know it's very important. And at that, I think I'm going to stop, because I think I've covered most of what it is that I need to cover, and we'll maybe catch up a little time.